Hi everyone, hope you're all doing good. In this video, we are going to discuss about amniotic fluid embolism. Amniotic fluid embolism is a life-threatening obstetric emergency. Okay. The presentation of amniotic fluid embolism is abrupt and it usually presents with sudden cardiorespiratory collapse that will be followed by severe coagulopathy and refractory resuscitation. Okay, that is resuscitation will not be possible. Usually, the survivors are also left with some complications like there can be cardiac, renal, neurological or even pulmonary dysfunction. Amniotic fluid embolism occurs in 2 to 8 per 1 lakh deliveries, and it is also the cause of maternal mortality for 7.5 to 10% of the maternal deaths. Clear? Right. Now, we will see the etiology. Usually, amniotic fluid embolism occurs with an unpredictable risk factor. Okay, but the possible risk factors can include increased maternal age, multiparity, male fetus, trauma. Sometimes induction of labor has also an association with amniotic fluid embolism. Also, the risk with cesarean section, placenta previa, eclampsia, even abruption, polyhydramnios, dilatation at curettage, and any chronic disease like renal disorders. These are considered to be some of the risk factors for amniotic fluid embolism, right? Now, let's discuss about the pathophysiology of amniotic fluid embolism. The entire process starts when there is an disruption at the level of placenta and the amnion membrane, okay, amniotic membrane interface. So, that is going to cause the amniotic fluid and fetal elements, including the fetal hair or the vernix or the meconium, even the squamous cells that has been renovated from the fetal skin and mucin, okay, to enter the maternal circulation. So, it can enter through various routes like the cervical veins, placental attachment site, or even the uterine surgical incisions. So, when it happens, there can be three possibilities. Okay. So, let us discuss one by one. So, the first possibility is that all these things are going to trigger an inflammatory response. Okay. So, because of this inflammatory response, there are so many mediators that are released. Mediators can include platelet activating factor, tumor necrosis factor alpha, interleukin 1, 6 or phospholipase A2, endothelin, thromboblastins and even complement factors. So, when all these things are happening, what happens is there is activation of the complement as well as fibrinolytic system. So this is going to cause a state of severe coagulopathy that will result in disseminated intravascular coagulation. Mostly 80% of the amniotic fluid embolism will be proceeding in this way. Okay. So you have to also understand that there is increase in factors like factor 10 or 9, 8, von Willebrand factor, then TFPI also. So this is tissue factor pathway inhibitor. Okay. So this is one possibility of amniotic fluid embolism. And in another side, what is going to happen is, there is uterus atony that is happening, and because of the hemorrhage that is collected inside the uterus is not going to contract and become to the normal state. So that is going to cause severe PPH. Okay. And the third possibility is that the amniotic fluid and whatever the fetal materials I have told that has entered into the circulation is going to enter into the pulmonary arterial tree, and this is going to cause pulmonary vasoconstriction as well as bronchoconstriction. This can also be associated simultaneously with dilatation of right atrium and ventricle. Associated tricuspid regurgitation can also be present. And what happens because of this dilatation of the right atrium and ventricle, the intraventricular septum is now going to bow into the left side. Okay. So intraventricular septum bows into the left side, especially the left ventricle, and this causes obstruction of the outflow tract. Okay. Because of this obstruction of the outflow tract, definitely there is going to be reduction in cardiac output, and there is increase in pulmonary arterial pressure further. Okay. So all these can result in hypoxemia, hypotension, and there will be sudden cardiovascular collapse. Can you understand? So these are the things that amniotic fluid embolism is going to cause. Clear? Yes. So when you do physical examination of the patient, you will be able to see a classic triad of amniotic fluid embolism, which consists of, number 1, there can be hypoxia or hypotension and coagulopathy. Okay. So this is the triad of amniotic fluid embolism. And if you do a fundoscopic examination, you will be able to see some small bubbles in the retinal arteries. Temperature in most of the cases is normal. So also the patient can be, repeating, the patient can be tachypnic. They can have a classic holocystic murmur, which can be high pitched as well. Yes, this occurs in case of tricuspid regurgitation, and this can be heard loudest at the lower left sternal border. Sometimes this can even radiate to the right sternal edge. Clear? Yes. And bleeding or hemorrhage can also happen. Sometimes it can be minimal, sometimes it can be severe also. Because of atonicity of the uterus, this is going to be around 83% of the cause for hemorrhage in case of amniotic fluid embolism. Initially, the bleeding will be from the vagina, okay, but later, repeating, initially the hemorrhage can happen only through the vaginal route, but later with full blown DIC, even if you put a surgical incision, that is also going to cause bleeding. Clear? Yes. So, how we are going to manage this patient? So, management consists of investigations first. So, let us discuss about the investigations. Investigations include bedside measurement of, repeating, see, while doing investigation, simultaneous cardiopulmonary resuscitation should also be done. Okay, so investigations and cardiopulmonary resuscitation should go side by side. Okay, so initially we will be performing some of the bedside investigations like measurement of pulmonary wedge pressure or cardiac output, repeating, cardiac output, central venous pressure, pulse oximetry, electrocardiography and chest radiography. So, these are the initial set of investigations you will perform by bedside itself. Then, if you consider some advanced investigations, you can go for transthoracic echocardiography or transesophageal echocardiography as well. Okay, so this is transthoracic echocardiography and transesophageal echocardiography. Okay, if stability is acquired, then you can directly prefer transesophageal echocardiography, right? And now the findings you may have in these investigations can include, there can be right ventricular dilatation. Yes, that is what we have seen in pathophysiology. This can be followed by hypokinesis or overload, and there can be tricuspid regurgitation, right atrial enlargement even. Okay. We already know the right atrium is going to be dilated and the septum is going to be pushed towards the left side, right. So, that will be presenting the interventricular septum in the shape of D. Okay. So, other than doing this advanced investigations, you have to do some basic investigations like you have to perform complete blood count or a coagulation profile. Okay. Then it should include your bleeding time, fibrinogen levels, D-dimer levels, fibrogen degradation products as well as partial thromboplastin time and activated partial thromboplastin time, etc. Right? Okay. There is a criteria that is given by American Society of Fetal and Maternal Medicine for DIC. So, we will see the important criteria that you have to arrive at all these investigations. Number 1, it should have a sudden cardiopulmonary collapse or hypotension with hypoxia, and hypoxia means the saturation should be less than 90%. Clear? Then DIC that is present according to the ISTH definition. Okay. ISTH means International Society on Thrombosis and Hemostasis. Okay. So, that should be based on 3 factors alone. You should see the platelet count, INR levels and fibrinogen levels. Okay. And this should be given up to a score of 10. Okay. And anytime if the score is more than 3, then DIC is confirmed. Clear? Right. The next factor is about the symptomatology. Symptomatology either during delivery of the baby or the placental delivery even, okay, and there should not be any rise in temperature, okay, temperature should be normal. So, then you can suspect that ASFM, repeating, if these criteria are all present, then you can diagnose amniotic fluid embolism, right. We will see how we can manage amniotic fluid embolism now, okay. So, in treatment, repeating, now we will see how we can treat the condition. So, prompt and effective CPR should be given for the mother as well as for the fetus. Then sometimes intubation may be needed. You have to give large bore IV fluids through the cannula, but remember there should be optimal fluid administration, okay, because if you give more fluids that will cause dilution of clotting factors, right. So, dilution of clotting factors can make bleeding even worse, okay. You have to check pulmonary arterial pressures by using catheters like Swanscan's catheter, and cardiac output measurement can be measured by thermal dilution. Pulmonary artery content can be aspirated and that can be checked for fetal components. Central venous pressure helps in assessing the right side preload. Urethral catheterization is needed to monitor the urine output, and early start of vasopressors like dopamine, dobutamine, epinephrine or norepinephrine can be done if there is persistent hypotension, okay. Addition of vasopressin can also be considered to increase the cardiac output. Drugs like sildenafil can be used to bring about pulmonary arterial vasodilation. Yes, if there is DIC in case of amniotic fluid embolism, you have to transfuse 1:1:1 ratio of PRBC, cryoprecipitate and platelets. And regarding the obstetric management part, cesarean section is preferred mode of delivery. So, procedure to control atonic PPH should also include your Beeline sutures, Heyman sutures, and if needed there can be ligation of uterine artery or even hysterectomy depending upon the condition, okay. And neonatal resuscitation has to be performed simultaneously by a neonatologist. Clear? Yes. So, this is about the management. So, what are the differential diagnoses of amniotic fluid embolism? Differential diagnosis of amniotic fluid embolism includes pulmonary embolism, peripartum cardiomyopathy, peripartum cardiomyopathy, septic shock, myocardial infarction, venous air embolism, eclampsia, anaphylaxis, and there can be chance of cephalad spread of spinal anesthesia as well. Okay. So, we will see what is the prognosis of these patients. So, prognosis, mostly this is a high risk for mortality. Okay. So, there is case mortality rate repeating. See, usually there is a case mortality rate around 40 to 60%, and maternal survival is uncommon, and even if they survive, they are left with some complications. Okay. So, 2/3 of the women who are survived, they can have complications, as I said, they can have complications with the cardiac system, neural system, renal system, etc. But sometimes even normal pregnancies after amniotic fluid embolism has also been reported. So, when you do an autopsy of the women, you will be able to see pulmonary embolism features like there can be amniotic component in lungs, alveolar hemorrhage can be there, there can be findings of myocardial infarction, acute renal failure, acute tubular necrosis, and even cerebral infarctions. Okay. So, I hope you would have understood what is amniotic fluid embolism, what are the various causes, what is the pathophysiology, and what are the obstetrics. So, with this we will be completing this topic. Until we meet in the next topic, keep going, happy learning, and take care.